Okay, everyone, we are at the top of the hour and I want to be mindful of our time because I'm sure Rochelle has a lot of information to share and it usually generates a lot of questions. So let's go ahead and get started. I'm sure I see a lot of familiar names, so I'm sure many of you are familiar with Rochelle, but I'd like to do a quick introduction for those of you that are new. First, my name is Molly Brown, and I am the director of the Heartland Telehealth Resource Center. We are glad that you're joining us today for part of our HTRC education series that focuses on telehealth billing, coding, and policy. Just a few notes little housekeeping items. This session is being recorded, and we will share it with you afterwards. Your microphones have been muted, so please unmute or use the chat to talk. Typically, we get a lot of things coming in, so it is easier to use chat, and I can help moderate that for Rochelle as we go through the presentation. Your completion certificates will be emailed. It's important to sign on with your first and last name so we can identify you. You can rename yourself by clicking on those three dots and clicking rename, and you can share your full name. You can also provide it in the chat. So let's get started. Rochelle Marting is a local attorney who's also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, and reimbursements, HIPAA privacy and security, health information management, and regulatory compliance. We're so glad to have Rochelle with us today. She's a very important education outreach partner with the HTRC. And today she's going to be talking about the Medicare final rule and updates on policy changes highlighting where Medicare and CPT rules align. I will now turn it over to Rochelle.
Right. Thank you, Molly. So this is kind of a part two to a session that we had earlier in the summer discussing the proposed rule that was in the Medicare physician fee schedule and some things that we were maybe seeing in the pipeline that may go into effect January 1 of 2023. The beginning of November, gosh, it's hard to believe that, is it tomorrow? That's the month of December already. Medicare released the final rule for 2023 in the physician fee schedule. And this covers a lot of provisions that are under the professional services benefits. So it's not just physician services, but a lot of professional providers. And telehealth has been for the last few years and continues to be a huge component of this. So there's a lot of information in this in the final rule. Some of it finalizing the things that were proposed, and in some ways making some tweaks and some changes. But it was over 3,000 pages in the final rule of policies and rules that are going into effect. So this is Medicare's quote, not mine, but I certainly echo this sentiment, where CMS says it's hard to contemplate a single aspect of evaluation and management visit coding that will not change in some way beginning January 1st, 2023. So there's a couple of things happening here. I'm actually going to go back one slide to give you a little bit of an overview on what we're talking about. In addition to just annual changes that are happening by Medicare, back in July, the American Medical Association released the text of CPT changes that were also happening January 1st of 2023. And among those were substantial revisions to evaluation and management services and coding guidelines and coding changes. A lot of those codes are also the codes that we tend to use with telehealth services. So we're dealing with not only some of the most substantial changes to evaluation and management coding and coding rules in the CPT book that we've had in nearly 2 decades, that affect how we code and bill for telehealth services. But we're also seeing changes in telehealth policy itself in this final rule. So there's a lot to unpack here. I'll do my best to cover as much as I can in an hour. And as Molly said, please feel free to add your comments to the chat. If I don't get to those during the session, I'll try to make sure I address those and we can send them out afterwards with information on the session and the slides. So just as a very quick overview, back in 2021, in the office and other outpatient services category for evaluation and management codes, in the CPT book, So this was not just Medicare, but this was all payers. There were some changes on how we select our codes for that narrow category of office and outpatient service codes. We moved away from, this is kind of a screenshot of a very complicated algorithm of check boxes to determine the extent of history and physical examination and medical decision making that was used to calculate the level of service that we billed, and instead focus on either medical decision making or time. And within medical decision making, the formula, the algorithm changed a little bit as well. That already happened within the code book. And now not Medicare, excuse me, CPT is extending that concept of getting rid of a complicated history formula, getting rid of complicated examination formulas, and instead just focusing on medical decision-making or time throughout the entire E&M section. So this is now extending to hospital codes, to skilled nursing facility codes, and other services within the E&M category of codes. With that happening, CMS Medicare in the proposed rule earlier this summer took a look at what was happening in the code book, took a look at Medicare's existing policies and guidelines for how we report codes and who can report codes, and started to develop its own policy and rules on how it will implement the changes that are happening January 1st, 2023 to evaluation and management services codes. So I want to start there by looking at how Medicare is applying or not applying some of those CPT concepts that will then impact how we code for those same services, whether they're rendered in person or whether they're rendered as telehealth services. So in CPT, one of the concepts that is within the CPT guidelines is that providers look at specialties and subspecialties to determine if providers of the exact same specialty and subspecialty are providing a service. That can dictate whether a patient is considered new or established. CPT also says that non-physician practitioners like APRNs or physician assistants are considered to be practicing in the same specialty and subspecialty as the physicians that they are working with. That is not how Medicare applies those same policies. Medicare, if you were to look at a provider's 855I enrollment form with Medicare, it only allows you to designate a primary specialty of practice. Medicare does not recognize subspecialties. So for Medicare purposes, providers of the same primary specialty in the same group practice help determine whether a patient is new or established, and will also dictate whether we can bill an initial hospital care code or a subsequent hospital care code that I'll talk about in just a minute. The other thing that's different about the way Medicare applies specialty and subspecialty rules, different from how CPT applies them, is that with Medicare, again, on that 855I enrollment form, when you're participating with Medicare, nurse practitioners and physician assistants have their own specialty designation. So for Medicare purposes, a nurse practitioner is not considered the same specialty as the physician that nurse practitioner is working with. The same thing for physician assistants. So some other differences between the CPT book and the way that CMS is going to handle some of the coding rules. In the CPT book, the guidelines for reporting an initial visit, like an initial hospital visit code, 99221 through 99223. Right now in the CPT book, only the attending provider gets to report an initial hospital care code. Everyone else, for their first visit with the patient, would report a consult code or a subsequent hospital care code. But beginning next year, that changes in the CPT book. And it changes so that any provider can report an initial hospital care code once per specialty and subspecialty during a patient's admission. That aligns a little bit better with how Medicare treats initial inpatient services, where Medicare currently and next year says that a patient being admitted as an inpatient could have multiple providers report an initial hospital care code. We would identify the attending physician of record with a modifier AI, and then other providers would report 99221 through 99223 for the first visit with the patient during a patient's admission. There's another change that's happening within CPT that I think could be fairly significant depending on providers' practices and whether they tend to see a patient like in the clinic setting and then admit the patient to the hospital and see the patient later that day in the hospital setting. Right now, under CPT guidelines, in that scenario, the provider would only report one evaluation and management code, and it would be the code for the final location of care, like the hospital setting. And all of the work that had been done that day from the clinic and the hospital could be combined together to increase the level of service. But next year, CPT will allow multiple evaluation and management services. The provider could report both the office visit code and the initial hospital visit code, applying a modifier 25 to the second E&M. But while CPT is making that change, Medicare is not. And Medicare is retaining their current rule that you would report only a code for the final location of care, like the patient's hospital services. So there's a lot of questions, a lot of Q&A that was discussed in this final rule. And I'll go through a couple that I think are particularly important or particularly helpful. So there were a lot of commenters to the proposed rule that asked how these definitions on new patient versus established patient, specialty designations apply when care is provided by a non-physician practitioner. And the commenters were asking whether care by a non-physician practitioner could be considered as a delivery by a different specialty. And if this is something different with Medicare, or if this is Medicare's current policy today. And Medicare clarifies that they're not changing anything about taxonomies or specialty designations with non-physician practitioners. In other words, when a nurse practitioner or a physician assistant, for example, enrolls to participate with Medicare, there is a box you check to identify that professional as a nurse practitioner or as a physician assistant, and that is the individual's specialty. And that is different than the specialty of the physician that NPP is working with. And Medicare clarifies that it has always been their policy that those non-physician practitioners who have their own specialty designation when they enroll to participate with Medicare have always been considered to be practicing in a different specialty than the physicians that they're working with. Another major change within the CPT book that Medicare also has to adopt, because it's happening with CPT codes, is that today we have a group of codes for admission and discharge for an inpatient to the hospital, and a group of codes for the admission and discharge from an observation level of care within the CPT book. That distinction from a CPT coding perspective goes away January 1st, 2023 for all payers, not just Medicare. to where the only codes we will have are what today we would call inpatient codes, but next year they will just be hospital care codes, and they won't distinguish between inpatient or observation status. So 99221 through 99223 will describe an initial hospital inpatient or observation service. And the way we distinguish between inpatient or observation isn't by the CPT code anymore. It will be by the place of service code that we use on the claim that identifies the patient as observation, outpatient, or inpatient. You will continue to use a modifier AI if the patient is an inpatient to identify the admitting or the attending provider of record on the initial hospital care code. One thing I think is, from a Medicare policy perspective, very confusing about having a single set of codes for an initial inpatient or observation visit is that Medicare's rules that determine who can bill an initial hospital service differ depending on whether the patient is an inpatient or admitted to observation status. Under Medicare's rules, not CPT, but Medicare's rules, any provider, the first time they see the patient as an inpatient, could report an initial hospital care code 99221 through 99223. And again, we just designate, we identify the attending physician of record with a modifier AI. But Medicare's rules are different in dictating who can report an initial care when a patient is in observation status. And Medicare's rules in that scenario say that only the provider who enters the orders for observation care and then is responsible for the patient during their observation stay can report 99221 through 99223 when the place of service will be an outpatient or observation status. Same set of codes, next year, different rules as to who can use that set of codes based on whether the patient is inpatient or observation status. So Medicare's rules aren't changing. It's just that there's no longer a second set of codes for observation status. They're now all bundled into initial hospital, inpatient, or observation care codes. There's some Medicare-specific rules to think about for prolonged services. And Medicare took a look at the CPT code 99418, which is what CPT will use for prolonged hospital services. And Medicare didn't agree with the way the American Medical Association valued that particular code and outlined the time increments that must be performed in order to use 99418. And so Medicare, for that exact same service, created their own G code that will describe a prolonged hospital inpatient or observation care service, G0316. Now, here's the complicated part. For Medicare, you would use this G code. For CPT, you would use 99418, but the time increments to report those two codes for prolonged services are different. If you're using the CPT code for non-Medicare payers, you could use 99418 whenever you have at least 90 minutes of service for an initial hospital care code like 99213. You could use it when there's at least 65 minutes of time for a subsequent hospital care code like 99233 or 99236, 100 minutes. Now look over at the Medicare counterpart. To use a prolonged service code for Medicare, G0316, the time increments are different. You could use that prolonged service code if you achieve 80 minutes, a lower threshold than the CPT counterpart. At 50 minutes for a subsequent visit, that's a lower threshold by 15 minutes for subsequent hospital care. But the last one, 99236, is actually a higher threshold to be able to report prolonged services for 99236 than the CPT counterpart. So it gets very complicated on when you can report prolonged services and what code you use based on whether the primary payer is Medicare or another payer. So I want to talk about split shared billing rules for just a minute. A split or shared visit is an encounter on a particular calendar day that is split or is shared between a non-physician practitioner and a physician. And split shared billing rules by Medicare give guidance on when you could bill that shared visit under the name and number of a physician rather than the non-physician practitioner. And the significance of that is that you could be paid at 100% of the Medicare allowable for that service rather than the lower 85% rate for a non-physician practitioner. Now, in the CPT book, split or shared services are defined also, but CPT does not limit that definition to any particular setting, like facility settings or non-facility settings. CPT also defines a split or shared service, but it doesn't dictate who can bill for a split or shared service, but Medicare does. And Medicare's rule is that the individual performing the substantive portion of that shared service bills for it. So that, of course, begs the question, what does it mean to provide a substantive portion of the service? This had been written into Medicare's manuals for years. And back in, I want to say 2021, Medicare pulled these guidelines out of the manual and invalidated them because they had never gone through the rulemaking process. But now they have. And Medicare says the substantive portion generally is more than half. It's determined by time. But we can also provide a substantive portion of the service if one or the other professional provides medical decision-making sufficient to meet the criteria under medical decision-making for the code that's being billed. So we have two ways right now that we can meet the substantive portion of the service by the physician. And if not, we would defer to the lower paying non-physician practitioner. Beginning January 1st of 2024, the ability to look at either the time or who provides the substantive portion of medical decision-making will go away. And the only option we will have to determine who performs the substantive portion of a shared visit will be based on time. And the individual who provides more than half of the visit would be the one to bill for the service, which also means in order to use the physician's name and number and to receive the higher rate of reimbursement, both individuals will need to be documenting their time. And we will need to have a way to compare those to see whose time was greater. And that will be the individual whose name and number needs to go on that split or shared service. A bit more Q&A on evaluation and management services from this 3,000-page final rule. For evaluation and management codes and the time that is identified with the typical time identified in the CPT book for those codes, CMS, Medicare said, we don't think that the CPT midpoint rule, this funny rule in the CPT book that whenever a code says a particular time, you could report that code as long as you pass the midpoint. So if a code says, for example, 30 minutes, CPT has this rule that as long as you pass the midpoint, 15 minutes and 1 second, you could report that code. And Medicare says, we don't think that CPT rule applies to evaluation and management services, but we don't really know what AMA's intent was. So we're going to defer to the American Medical Association to give guidance. So I would anticipate that probably sometime in 2023 in the AMA CPT assistant publication, we may see guidance on whether that midpoint rule is intended to apply to evaluation and management services. A really interesting point or clarification that Medicare made in the rule about the level of service that you select for an evaluation and management code is really, it's a billing concept, right? Whether a service is comprehensive or complex decision-making, that's a billing rule. It doesn't change underlying conditions of participation for facilities like hospitals or surgery centers that may have requirements to perform a comprehensive history and physical examination prior to surgery. So that's something to keep in mind. That's an entirely separate concept that's dictated by federal regulations and hospital or ASC bylaw, medical staff bylaws and rules and regulations. There's also a concept in both the CPT book and in the Medicare rule about a service that crosses midnight. A continuous service that crosses midnight would be reported as a single service rather than two separate services. But Medicare doesn't define what it means to be continuous. For example, if there's a brief interruption where a provider answers a page or answers a call on another patient, then immediately jumps back to focus on that first patient. Is that continuous or is that interrupted? CMS declined to provide guidance on that and again deferred to the American Medical Association to provide guidance because that word continuous is within the CPT book.
Rochelle, we have a question from the chat.
Sure.
On that last slide. Would you think the AMA would be incentivized to adopt this midpoint convention for EM codes?
You know, my inclination is that CMS or Medicare's interpretation on time beat for evaluation and management services for I should say, I'm getting into my attorney brain here. Most evaluation and management services, there are some that I think are exceptions. The typical time for like an office visit code or an initial hospital visit code, when the codes were changed, was described as a threshold and not subject to the midpoint rule. And I think if we see AMA CPT guidance, it's probably going to adopt that same interpretation. If you were to poll the American Medical Association Resource Utilization Committee, the RUC committee, their resources on how they have valued these services and the typical time, they're looking at actual pre, intra, and post-service time to adopt those times that you see within the CPT book. So I also don't think the intent was to use the midpoint rule, but I've been wrong before. Ask my husband, and we'll see what AMA provides guidance on if they decide to issue guidance within the CPT assistant or even within the CPT book during future revisions next year. Good question. There's a current CMS policy on when and how you report initial hospital care and discharge care or same day admission and discharge codes based on how long the patient is in the facility, either on a single day or across 2 days. Now, if you were to go into the final rule, you would be reading for 15 pages, a very narrative and complicated description of this. And then at the end of that, there's this table. And I thought, why didn't they just put this table at the beginning? Because this really simplifies it, I think. If a patient is admitted to the hospital and discharged from that same facility on the same calendar date in less than 8 hours, the only code that gets billed is an initial hospital visit code. There is no discharge service code that's billed. If the patient is admitted to a hospital, discharged on that same calendar day, but the total duration of stay was more than 8 hours, report a same-day admission and discharge code. If the patient is admitted to a hospital, discharged the next calendar day, but the total stay spans fewer than 8 hours, still only report an initial hospital service code. If a patient is admitted to the hospital, discharged the next calendar day, and the total duration of the stay is greater than 8 hours, report an initial hospital service code on day 1 and a hospital discharge code on day 2. This I've kind of discussed already, where Medicare was discussing what they're going to do now that there are no longer separate hospital observation care codes. Those were deleted. They were kind of bundled into what we today would call hospital inpatient codes, but next year they will be used for initial or subsequent hospital inpatient or observation care. 99221 through 99233, or 992, let me say that again, 99221 through 99223 for initial services, 99231 through 33 for subsequent hospital services. And Medicare is just clarifying that the policies that they currently have in their billing manuals as to who can report an initial inpatient or initial observation code will remain, even though the codes for that different status are the same. The rules for who or how many providers could report initial hospital care will be different based on the patient's status. Okay, and I won't read the entire question and comment, but this is the language from the final rule that you can refer to with some of the citations if you need to go back and look at that later on. So lots of things happening with evaluation and management services. I'm going to switch gears now and talk about remote patient monitoring, and not so much what I've been calling RPM codes, but RTM, remote therapeutic monitoring, newer codes that were added to the medicine section of CPT so that professionals like speech therapy, physical therapy, occupational therapy, whose scope of practice doesn't allow them to report evaluation and management codes, where our PM codes are classified, could monitor patients and still bill for that remote therapeutic monitoring. And Medicare was kind of challenged with the way these codes were described in the CPT book, because just like there are PM counterparts, the monitoring that goes on a monthly basis may involve a physician that's doing the monitoring or the treatment management, but clinical staff may be actually monitoring that physiologic data and reaching out to the patient saying, Rochelle, you didn't take your blood pressure this morning, or we see your weight is up 3 pounds this week. We need to manage your congestive heart failure or adjust your medications, and so on. So that clinical staff is involved in RPM. The RTM codes have a similar concept where clinical or ancillary staff may be involved in monitoring therapeutic responses to treatment. But the issue Medicare had with that is unlike physicians or nurse practitioners who have an incident to benefit under the Medicare program, physical, speech, and occupational therapists don't have an incident to benefit under the Medicare program. So Medicare was going to take the RTM codes, mirror that with new G codes that just don't have the option for some of those services to be provided by clinical staff. Medicare did not finalize that proposal, and they have a lot of discussion on how they're going to handle that kind of nuance within the CPT book. So I think that's for me, that seems like a positive change, that it's all one set of codes regardless of who the payer is when you're using remote therapeutic monitoring.
Rochelle,
Yes.
would the remote monitoring codes include mental health therapeutic clinicians?
So, okay, so that's a great question. They could. The remote therapeutic monitoring codes that were newly added, I want to say 2022. I'm getting my years are running together. I can't remember if it was 21 or 22. I think it was 22 to the CPT book, and Medicare agreed it would cover those services as well. They're a little bit different than what we had for RPM, which was physiologic parameters like objective data, right? Blood pressure, heart rate, pulse ox, that's going directly from a device measuring those physiologic parameters to the provider. But RTM captures more subjective data. There are codes for monitoring musculoskeletal and respiratory status responses, but it can be used for other purposes as well because it's the patient's subjective response to treatment and therapy. So we can certainly dive into those different uses in the mental and behavioral health context and how they may be used in conjunction with behavioral health integration or psychiatric collaborative care, and how they can't overlap with those services as well. But that is an option that I'm seeing some providers take advantage of. So switching gears a little bit, we've talked about changes that are happening in the code book for all payers, how Medicare's policy for evaluation and management services may align in some places or differ from what CPT is doing for all other payers. And now what's happening with telehealth policy, where we may be using those evaluation and management services to bill for some of our telehealth services. So in this final rule, there are a number of additional extensions, a number of additional flexibilities that are favorable to providers in terms of telehealth policy. All of this with an eye towards what is happening or what will happen when the federal public health emergency ends. And a lot of the flexibilities with telehealth that we only have available because of the public health emergency and because of Health and Human Services' ability to create rules that may contradict what is in the Social Security Act that was passed by Congress, that are only available as a result of the PHE. And when those go away, how does that impact telehealth that we have become so accustomed to? So one thing that I want to continue to urge everybody in this session, in your telehealth delivery, the date to submit requests to add services to the covered list of telehealth services is February 10th of each year. So we're coming up on that. When you submit a request for a telehealth service to be added to the list, or to take a service that is currently temporary and make it a category 3, or category 3 and make it a permanent telehealth service, provide as much data as you can on how it improves access, how it improves quality, how it improves outcomes. And there's a page on the CMS website that you can submit those requests to. I'm going to try here to see if I can show you where we can submit those on CMS's website. So I'm going to pause. If you've got your camera on, if you can give me a thumbs up if you can see my internet browser, just to make sure. All right, Molly's giving me a thumbs up. So right now I'm going to the CMS website. I'm going to search for, that's not how we spell it, telehealth. And if you search for telehealth, submitting a request, right, there's a link on how you can do it. There's a page on requests for additions that says exactly what you need to put in there. So this is your kind of homepage for what to include to have a successful request to add services to the list of covered telehealth services under the Medicare program. And I say that because for the last several years, Medicare says that none of the requests received by the February 10th deadline met criteria for a category 1 or category 2 criteria to be permanently added as telehealth services. And on that page, there's a description of what it means to be a category 1 permanent telehealth service and category 2 permanent telehealth service. That will help guide you to the information that you need to supply to have the best chance of success when Medicare considers those requests in the proposed rule that will come out next July. So some more changes that we saw in the final rule relating to telehealth. We have these two categories of telehealth services that have been created as a result of the public health emergency. One are temporary telehealth services. They were added to the list of covered telehealth services just as a result of the PHE, and previously or as proposed would go away the day the public health emergency ends. Category 3 was created as a bucket of services that were also added to the list of telehealth services as the result of the PHE, but Medicare thinks they have a chance, or they would be candidates to add as permanent telehealth services, but they need more information. They need more data from providers from the community to be able to add these as permanent telehealth services. Previously, these codes would continue to be covered as telehealth services through December 31st of 2023. As of right now, there's no extension to that date. However, there is some federal legislation that has passed the House that is waiting to be voted on by the Senate, and we think that may happen within the next month or two, that would extend these services through the end of 2024, an additional year, even if the public health emergency were to end in January or in April of next year. So there were some changes in the final rule. That temporary bucket, the things that would have gone away the day the PHE ends, there was a new extension. So all of those telehealth services will continue to be available for 151 days after the public health emergency ends. As of right now, the public health emergency will run through January. If the secretary intended to allow it to expire in January, we should have gotten notice of that about 2 weeks ago, and we didn't. So all signs are pointing to another 90-day renewal, which would take the public health emergency into mid-April. There's nothing formal, but there are rumblings that could be the last 90-day extension. Of course, I've said that before. We've had those rumblings before. So we'll see what happens about February, mid-February. If it is renewed again, is when we should see a notice that it will be allowed to expire. And if we don't, that might signal an additional extension into the summer of 2023. So for category 3 codes that are already available through December 31st, 2023, that could potentially be extended another year if the Senate passes legislation that's currently in front of them, Medicare said we may, if the PHE continues to extend well into 2023, we may consider revising that policy next year in the proposed rule to continue to cover those services through that 2024, which they may in fact be required to do if the Senate passes that bill that's in front of them. There are also some therapy codes, speech, physical, and occupational therapy codes that were currently in the bucket that would have ended the day the PHE ends. Now we go 151 days after the PHE ends, but they were moved to category 3, which means they will continue to be available through at least December 31st of 2023. Probably the way things are looking through December 31st of 2024. But need to caution everybody using these therapy codes by speech, physical, and occupational therapists. Even if they are available as covered telehealth services on the telehealth list through December 31st of 2023 or 24, depending on what happens with legislation. 151 days after the public health emergency ends, which could be before these codes drop off the covered telehealth list, speech, physical, and occupational therapists will no longer be eligible distance site providers to provide telehealth services under the Social Security Act. So those dates may differ. We'll have to keep an eye on that next year. I won't read through this slide either, but this shows you the codes that were moved from the temporary bucket where they will no longer be eligible as telehealth services 151 days after the PHE ends to category 3, making them available as covered telehealth services at least through December 31st of next year. Oh no, so just a moment. I had an audio on a recording. Just a minute here. Sorry. Let me stop sharing and close my. I thought I had gotten all my audio off. Just a moment. Let me double check that now. I think we've got it now. Okay. Share again with you. Okay, so part of what was in the temporary bucket that would have gone away the day the PHE ends, but is now available through 151 days after the PHE ends, were audio only service codes, telephone visit codes. Those were considered, but were not moved to category 3, which means they're only available 151 days after the PHE ends. But as I've got on this slide, watch for federal legislation, which may require Medicare to cover them longer than that. Okay, so here are the list of codes that will continue to be available 151 days after the PHE ends. This isn't really a significant change. I'll just have it on this list so you have these available. All right, so a couple of other things that are going to happen. No longer the day the PHE ends, but will continue to be available for 151 days after the PHE ends. The originating site, meaning where the patient is located. Medicare just formalized in their rules that they will follow legislation that was passed earlier this year in March that says anywhere the patient is located within the US is an eligible originating site. That's actually more expansive than what we have during the PHE. During the PHE, of our list of eligible originating sites, like a physician office, a critical access hospital, FQHCs, RHCs, we just added a little bullet point to the end that said the patient's home. But after the PHE ends and for 151 days afterwards, it's not just the patient's home, it's anywhere the patient's located will be an eligible originating site for that 151-day period. RHCs, FQHCs will continue to be eligible to bill as distant site providers of telehealth services under the Medicare program. That was passed by Congress. Medicare was just formalizing that in their rulemaking. And remember that one of the notable exceptions or omissions maybe to that policy is that critical access hospitals, which during the PHE can bill as distant site telehealth providers, will not be able to bill as distant site providers effective the day that the public health emergency ends. Now, I have a major clarification for a lot of you who have asked questions about the 6-month in-person visit requirement for certain mental behavioral telehealth services 151 days after the PHE ends. We've had a whole session dedicated just to that topic, but I've got good news for you. Previously, Medicare was asked, what happens for those patients who have been seen for mental behavioral telehealth services at home for the last almost 3 years during the public health emergency? When the PHE goes away, when that in-person visit requirement kicks back in, do they have to have an initial in-person visit before having another telehealth visit for mental behavioral health services at home? And Medicare clarified that the answer is no, that those established patients who have been receiving mental behavioral telehealth services at home throughout the PHE will not need an initial in-person visit after that. They will still need the periodic annual in-person visit, but there are exceptions to that requirement if the risks outweigh the benefits of having that service. So that's a very favorable clarification to that. And I think we may have legislation in the meantime where that requirement never kicks in at all, knock on wood.
Rochelle?
We've got, oh yes, Molly, go ahead.
Really fast. We have a couple of questions in the chat box. I get the impression they may be a little detailed. Would you like, considering the rest of your slides, would you like us to note those and maybe send them in email form?
Yeah, if we've got nuanced questions in the chat, let me continue through the slides and see where we get. If we've got time, I'll go through those questions. And if not, I'll make sure I respond to them that we can send out.
Okay, perfect. Thank you.
When I went through and kind of recorded this information, it was about 1 hour and 17 minutes. So squeezing it into an hour already from 3,000 pages to 60 minutes is already a task. But I may just leave this particular slide with billing instructions and things that are going to change 151 days after the public health emergency ends in terms of telehealth place of service reporting, which will revert back to pre-COVID rules, if anybody can remember what those were, and modifier reporting for telehealth services, reverting back to pre-COVID rules. Now, Medicare, one of the things they clarified, though, is that they will continue to allow for payment at the place of service where the service would have been rendered if it was delivered in person through December 31st of 2023. That is presumably an extension because previously it said 151 days after the PHE ends. So there's a couple of things that I think are notable there. That signals to me April would be kind of the prime time frame for the PHE to end. This was written to be an extension. If the PHE were going to extend into July, 151 days is about 5 months, and that's about the end of the year anyways. So we may, if the PHE were to continue and we have additional surges of COVID, I would expect this to be addressed in next year's policy with additional extensions as well. So 151 days after the PHE ends, facilities could use place of service 02, which is a telehealth place of service again, but that could decrease your reimbursement if the originating site is a non-facility place of service. If you're a facility place of service, it won't matter whether you use place of service 02 or the more specific place of service code where the service would have been rendered. The benefit of this is non-facility locations can continue to get the benefit of the higher non-facility rate of payment through December 31st of 2023. There's another good clarification that was really, I think, mixed up in the proposed rule that suggested that when a telehealth service is rendered incident to the professional services of a physician or other qualified healthcare professional. Right now, I should say prior to COVID, incident to requires direct supervision, which meant though the supervising provider and the individual rendering the service have to be physically in the same office suite where the provider is immediately available. For telehealth, that didn't make a lot of sense, particularly if the supervising provider was quarantining or home, but well enough to intervene in the middle of the telehealth service, or maybe the rendering individual is working from home. So there was this option during the PHE that said virtual presence of the supervising provider, the availability to immediately intervene during the telehealth session can meet that direct supervision requirement. That will go away when the PHE through December 31st of the year when the PHE ends, and would then go away. But telehealth services could still be rendered incident to. It just means the supervising provider and the rendering clinical staff or other person would need to be physically located in the same office suite. There is still kind of an asterisk on this where Medicare says they're going to continue looking at this with future rulemaking. So we may have a different policy come July when the proposed rule is implemented or is released. Now, we had a question from someone attending this afternoon on behavioral health services and remote therapeutic monitoring. Also new this year, something we could potentially have a whole other session on, are new codes for chronic pain management that look and work much like chronic care management for other chronic conditions, behavioral health integration and psychiatric collaborative care that are specific to mental and behavioral diagnoses. Now there are similar codes for the non-face-to-face management of a patient's chronic pain diagnoses. So I'm going to put the codes in the slides. I won't read through the codes definitions, but you can see they're pretty lengthy, just like chronic care management and behavioral health integration codes are in terms of what they require, what services are a part of these codes. The time increments for these throughout the calendar month also work the same or similar as chronic care management. And Medicare clarified that this add-on code, right? This is an add-on to the initial 30 minutes of chronic care management in a month. And each additional 15-minute increment, there's an unlimited number of units that could be reported for those additional 15-minute increments. Couple of important definitions for these chronic pain management, these non-face-to-face services that are not technically telehealth under the Medicare telehealth benefit, but they're non-face-to-face services that can be done under general supervision. A couple of things: consent's required, verbal consent's okay. We have to get that consent documented in the record because there will be patient cost sharing for participating in this chronic pain management program. Medicare doesn't expect that multiple providers in a single calendar month would be rendering chronic pain management to a single individual patient, but it could happen. You can see my kind of highlights going on here, that the initial face-to-face service has to be an in-person service, and that these are limited to the office or other outpatient setting for patients. They can be billed during the same calendar month as chronic care management for other care services and behavioral health integration. Not all of the elements have to be rendered in person, but the face-to-face visit has to be rendered in person and not via telehealth. So care planning, coordination, those are pieces of the service that may be prime for delivering as a non-face-to-face service, non-in-person service. These aren't limited to a particular specialty, so you don't have to be an interventional pain management or anesthesia provider in order to bill for the chronic pain management services. We're right at the top of the hour, but I do want to cover this clarification on behavioral health services that I think is really, really important for when the PHE winds down. Because I talked about virtual presence as a way to meet direct supervision for services rendered incident to a physician or other qualified provider services will go away the end of the calendar year when the PHE ends. But there is a carve out for mental and behavioral health services. This is not limited to any specific diagnosis, or excuse me, CPT code. It's determined by the diagnoses on the claim that fall within the category of mental or behavioral health conditions. And for services rendered incident to a physician or other qualified provider, for mental behavioral health conditions as identified by the diagnoses on the claim, those services can be rendered under general supervision rather than direct supervision. That's a huge exception that is going to make mental behavioral health services much more accessible beginning January 1 of 2023, regardless of when and how the public health emergency ends, and extending to the policy for telehealth services. Unfortunately, that allowance to provide them under general supervision doesn't extend to FQHCs or RHCs. I've got a couple of codes here that I'll just put the description of the codes on the slides because I know we're running short on time, that I want to make sure you've got access to as new codes that are behavioral health integration that's performed by psychologists or social workers that Medicare will begin paying for beginning January 1st of 2023. And with that, with only going 2 minutes over, that is the 3,000 pages of the Medicare physician fee schedule beginning January 1 in only 62 minutes.
Thank you, Rochelle. We do have questions in the chat, and we are taking them down. I do have a couple direct messages I also received, so I took those down as well. Thank you all for attending today. Thank you, Rochelle, for that wonderful information. We will be getting our follow-up email out to you all as soon as we get it compiled, including responses to the questions in the chat. Also, please keep a lookout on your email because we will be having our December webinar coming up on December 14th, where we will be covering payer policies information related to things maybe outside of CMS. Is that correct, Rochelle?
Yes.
Right, got it. Okay. Well, thank you all for attending, and please look for the follow-up email that we will be including with the recording link, PDF of the slides, and then responses to the more specific questions in the chat.